Thanks for joining us. I'm your host, Raquel Faria. I am a doctor in internal medicine at the Centro Hospitalar Universitário de Santo António, no Porto. Today, I'm joined for the first time by the chair of Lupus Europe and patient Jeanette Andersen and Professor Ricard Cervera and Maria Dall'Era from the Lupus Academy Steering Committee. Jeanette, Ricard and Maria, welcome and thank you so much for joining us today. As you can imagine, today we are going to discuss the importance of the patient perspective in the management of lupus. We will try to discuss two major topics. Let's see how it goes. What's the role of the patient representative and some pitfalls on the patient-doctor communication? So we are in 2023, and despite I see lupus patients for 14 years, I only learned the real meaning of a patient representative last October, and I was amazed. And I really think there is still lack of medical knowledge on the role of a patient representative. So, Jeanette, you are very important today. You are going to educate us on this. Can you please describe the concept of patient representative? Who are the patient representatives in your country and in Europe? What is the role of the patient representative, both in your country and in Europe, since you are the chair of Lupus Europe?
Oh, that's a lot of weight you're giving on my shoulders right now. So I hope I can do it justice. So actually, there are different kinds of patient representatives. I think we all know the normal, in brackets, patient representative, who is sort of a patient advocate, a person talking about the disease, how it is to live with the disease, trying to make people aware that this disease exists and what the dangers of this disease and the needs are. Those can be both patients, but also carers or other people around the person with the disease.
Yes.
And then we have what I think you're thinking of, which is patient representatives who are a bit more educated, have a lot of experience from many years of being a patient advocacy person or in touch with other patients in the same disease area, and can give expertise to, for instance, clinicians or researchers. And some of them are very educated, which means they've taken courses where they've learned about medical research and can actually speak the same language as researchers and can help them in their research. They know about the different phases of medication and so on, and can enter at the same level. Those are, for instance, the ones we have in Lupus Europe, where we have patient advisory network members who are more or less educated and have taken courses like UPATI or EULAR PRP courses, patient research partners. And then, of course, there are some differences from different countries where what the normal thing is, how you are a patient representative, where some countries have more patient advocates, where it's more about raising awareness of the disease. Yes. And other places, it's more focused on the research part or on the consultant part of being a patient representative.
Thank you so much. So if you are a patient, and we are actually talking about lupus, if you are a lupus patient, what is needed to be a patient advocate? The first line that you were saying, the normal patient representative, what is needed?
Well, for the first thing, the normal one is you need to have a knowledge about the disease, of course, and the impact it has on patients. It's very much about the impact that this disease has on the individual patient and on society, and bringing that forward, telling other people how it is to live with this disease. So that's actually the only, I say that also in brackets because it's a lot of experience you need to have, but it's very important role, but that's the only expertise you need to have, simply knowing how it is to live with the disease.
And do you think that these patients' representatives, the advocates, should work in patients' association, should join the patients' association? How do you see this for a patient? What would you recommend for a patient?
from my point of view, I would say yes, it's always an advantage to have these people connected with the patient organizations, because then we can organize our efforts. We can make sure that we have the same focus. We can make sure we don't go to the same media twice with the same message, because then we might drown in other messages. So it's always a good idea to be connected, no matter which level of patient representative you are. It's good to have a basis in a patient organization.
I'm going to ask Ricard and Maria their experience, but I really wanted you to comment, because I do have patients that they try to join the patients associations and they just say that so much disease that I was not feeling okay being in the association. Is this your experience? Please comment on this.
Yes, unfortunately, we see that a lot in different patient organizations, that the focus is very much on the disease, being sick, and telling each other how sad it is and how bad they feel, and instead of picking each other up and focusing on a message or something we want to fight for. And that's what we are trying to change. We can't do much, but we can try in Lupus Europe by giving advice, by inviting people from the national organizations to our meetings, telling about our experiences and what our focus is for the next year, for the next 5 years, and maybe that way trying to have a focused direction and to let them know what's going on the global plan as well, because often it helps if you are even more patients involved.
Yes. Ricard, what is your experience with the patient representatives in Spain? Not only in Barcelona, but also in Spain. What is your insight about this?
First of all, greetings from Barcelona. I am very pleased to meet you again for this podcast, and especially to talk on patient's role in our work, in our daily work. And also, first of all, I would like probably to stress how proud we lupologists should be, because we were one of the first specialists that put the patients in the center of our meetings, of our works, of our daily work. One of the first patients' congresses was the Lupus Patient Congress that was linked to the, let's say, specialist Lupus Congress in the 80s and the 90s. And since then, we have, I think, do a lot to work together, patients and physicians in the field of lupus. And I have to tell you that I always stress to my students how important is the relationship between the patient and the physician in our job. And most people probably believe that this relationship between the patient and the physicians means that the physician just gives something to the patient, just treat, just try to cure if possible, if not at least to control. But I think that this relationship is bidirectional, and we receive a lot from the patients. We receive knowledge, so is teaching is something that is performed thanks to the patients, and also we receive more inputs for doing research, for trying to know the answers to the many questions that our patients put to us. So I think patients are essential in this work that we are doing. In our specific case, I think not just in Barcelona or in Spain, but I think in Europe, I think that we probably are trying by means of the patients' associations in the different countries, in the different regions or cities, we are trying probably to put the patient in this central role. We organize meetings for interchanging the ideas, for increasing the knowledge of the patients on the disease. Always, if a patient is well educated, the patient probably will fight better against lupus, against the disease. Also, it's very important to have patients for our research purposes. If patients want that we know how better treat this disease, they must be involved in the research projects that we perform. Also, they are in first line for the connections with the administration. And we have excellent results due to the work that they have done talking with the government. Thanks to the Patients Association, now we have many things that just because we physicians would do our work or probably go to plead with the politicians, we would not be able. It is thanks to the patients that we have been able to do these things. So these are some, but not all, probably we will talk later on more examples of this collaboration, this great job that lupus patients are doing in Europe.
Maria, what's your experience? You live in a different country, different world. What's your experience with the patient representative?
Yes. So I live in San Francisco, California, and similar to Ricard, I think I see patient representatives as being crucial in many aspects of the things that we do to advance lupus therapies and improve the lives of all people living with lupus. And to give some examples that are similar to Ricard, I've seen, maybe we're a little bit later to this than it sounds like Europe, but I would say in the past 5 years, I have seen a noticeable shift in that what we are doing is involving patients with lupus or people living with lupus directly into the planning of our conferences. And Ricard mentioned this as well. And so we have, for instance, a meeting coming up in a couple of weeks, and then another one at the end of the summer, where patients actually formulate sessions at the meeting, but they also participate in all of the scientific sessions so they can give their input throughout. And we construct the meeting in such a way that we ask the presenters that are presenting the scientific research findings to also present those findings in a way that is applicable to the patients in the room. So really trying to integrate the patient voice with the researchers in the room, because as Ricard said, that is absolutely critical because we are doing research to benefit people living with lupus. So we have to understand what is most important to them, because we do know from various studies that often what is important to our patients is not exactly what may be important to the physician or what the physician might be focused on, right? Yes. And that's where patient-reported outcomes come into play. And then another aspect, I would say, of the patient representatives, and again, Ricard mentioned this as well, is we are now, I think, becoming very good and cognizant of the fact that we need to integrate lupus patients into designing clinical trials. So we make sure that we are looking at outcome measures that are relevant to people living with lupus, but also design trials in a way that people can actually participate. One of the big issues we have right now in the United States is the challenge of enrolling patients into these pivotal clinical trials. If we can't enroll people into trials because the trials are just impossible for people to participate in because of the frequency of the visits or the length of the visits, if we can't enroll people in trials, we're never going to make advances, right, in terms of lupus therapies and really improving lives of people living with lupus. And so we've learned this lesson. So to have lupus patients at the table helping to design these trials and telling us, wait a second, we can't have somebody come every single day for a blood draw because, this person has to take care of their 3 kids at home or they have to work full time. That's been absolutely critical. And then the patient voice with the regulatory agencies. So in the United States, that's the Food and Drug Administration, their voice at the table saying we need new, more effective, safer therapies for lupus. So advocating in that way. And then, of course, advocating, as Ricard said, with our national funders, with our government, to be able to acquire funding for these various research studies. So I think there are these multiple facets here by which patient representatives are absolutely critical. I think finally in the United States, we've realized this. And I've seen it, like I said, a major shift over the course of my career in understanding this. And I feel very optimistic for the future that we now have patients in the room with us in all of these different aspects, so we can really move the field forward.
Thank you, Maria. Thank you for your opinion. I think that huge highlights, both from Jeanette and both for these two experts that live in Spain, Europe, and the United States. And actually, we don't know how it works outside Europe and North America. But probably, I don't know, Jeanette, if you have any insight of other Asian, African relationship between the patient's representative and doctors and research. So can you please try to tell us, what do you think are the main differences in the patient pathway, in the lupus patient pathway, both in Europe and North America? And what do you know of other parts of the world? I know this is a challenge, but can you please tell us, what do you think of, what is the patient pathway for a lupus patient?
Yeah, so I'll give it a try. So as you guys know, but maybe people at home don't know, lupus is a very heterogeneous disease. No two lupus patients are the same, neither are their pathways. So they look very different. I can say that on a global scale, there's between 2 and 7 years delay in diagnosis of disease. So it actually differs a lot from person to person and from country to country. We know that some countries are quicker at catching lupus, but in general, it's a very difficult disease to sort of pinpoint and diagnose. It's difficult because the symptoms are so varied and they imitate other diseases. So often you'll get another diagnosis first before you get your lupus diagnosis, especially if that diagnosis is fibromyalgia or depression. There's an even longer time before you get diagnosed because everything just gets poured into those buckets, and you don't look outside for another disease. So it's 90% women. They are youngish, so 30, 40 years of age. Often it's when they have their first child. So we know that hormones play a role. It can be a very difficult time to get a chronic disease because you're sort of starting your life, planning a family, planning a future with perhaps education or a job. And it's very inconvenient, let's put it like this, to get a chronic disease, and you need to take medication for the rest of your life. We have patients who have intermittent remission and flares. We have patients who only have one flare and then are in remission for almost the rest of their lives. So it's very unpredictable. Normally, I think the most normal thing is to have some flares once in a while. So with a few years in between, having a flare more or less severe, and then going into remission again. We don't have a lot of treatment options, not that are approved anyway. So we sort of, for a physician, it's more or less trial and error. We will try this medication and see how it works on you. And if it's a success, great. If not, we'll try something else. And that can be very frustrating for both physician and patient. So not knowing what you're trying, if it works or not. And often with quite a delay in the effect of the medication as well. But in general, it's taking medication for the rest of your life. So that's more or less how it could look. And that's, if you're looking North America and Europe, it's very similar. I know that if you look to Asia, if you look to Africa, it's a completely different story. Because actually most of those people are not diagnosed. Some of them will never ever, most of them will never ever see a rheumatologist. They might be lucky to see a GP, and they probably won't know about lupus. If they do, it's a wonder. If by chance they are diagnosed, They have to pay for their medication. I know that's also the case in other places, but often they will have to decide between paying to get treatment or paying to feed a family. And we all know what you would choose. So we see a lot more deaths in those areas simply because it isn't catched or treatment isn't available for one reason or the other. So it's a completely different picture you get. And that's, we all know that there's a lack of rheumatologists, both in Europe and in the US, but actually it's even worse in those areas where they are far between doctors in general.
Lots of work to do to try to put lupus a little better. And although we do not have so many treatments approved, we actually in Europe and North America have so many other treatments than steroids. So we are really facing different realities in different parts of the world. Thank you, Jeanette, for letting us be more aware of that on the patient perspective. And changing a little bit, but continuing the subject, we often hear, as you said, the discordancy between the patient's and physician priorities. And Maria also stressed it on the research part of it, and Ricard also stressed it. And Jeanette, can you please share your perspective on what are the main patient priorities when it comes to treatment of lupus?
Yeah, I'll try. Again, it's my view and from my experience in the past. But first of all, getting the disease under control when you have a flare is absolutely number one. It will be for every patient and for all physicians, I'm sure. But then we need to look at, now my lupus is under control. I've sort of gone through that first flare, or maybe gone a bit further in my life. And then we begin to think about other things. So we think about quality of life. So which kind of life can I have moving forward? I still want to do things that make me happy. I still want to focus on areas that are important to me. There's also a focus on mental health. So making sure that you are feeling well about yourself, about your role in society, about your family situation. By having this disease, you tend to sort of draw back from outside things. So instead of going out to parties, you tend to stay home because you get too tired. You don't want to expose yourself too much to diseases, and sort of isolate yourself a bit. And that's a big problem for many lupus patients, which we're trying to address. We know that from a survey that we did in Lupus Europe a few years ago, that around 40-50% of people with lupus actually have a depression. And most of them are not medicated. So, or they don't address the topic of depression with the physician. So it is a problem that's not addressed. That's just some of the things that lupus patients focus on, which I think is different than doctors might think immediately.
Ricard, if you didn't hear Jeanette, and if you try not to know what are the patient's priorities, because of course you do know, and you work with patients representative for several years, what would you, a list of priorities for treatment of lupus, and what are the commonalities between these two lists? What are your priorities when you treat lupus?
Well, actually, we are also changing the way that we are addressing the concept of treating lupus. Probably until recently, we were more focused on controlling disease activity, controlling nephritis, controlling central nervous system manifestations or thrombotic manifestation, the antiphospholipid syndrome, all these, let's say, fashion manifestations for lupologists. But nowadays, we know that the most important thing is to prevent the organ damage that is accumulated over the years, and that probably will not give a terrible problem very soon, but will for sure give a lot of problems in the years that will come. And this will also decrease the survival of our lupus patients. And this will also decrease the quality of life or the organ work of or the work of the different organs. So nowadays, as lupologists, our fight is prevention of this organ damage over the years. So probably the important thing now is how to put together these two ideas to improve the daily quality of life of our patients. That is what they want at the first. They probably know that in the years to come, they will have additional problems, but they want to have a better quality of life right now. And what we consider that from a medical perspective is very important, that is to prevent this damage over the years. So it's a very tricky situation. We have to combine these two aspects.
Maria, can you please say your priorities? They're not going to be so different on this, and please comment on what Jeanette stressed: the depression and the fatigue and the isolation. How do you address this in your daily consultation and practice? How do you address this?
So I think this is such an important conversation, and I have to admit this is a struggle. We're trying to figure this out. And I agree with how Ricard presented this, that, you know, as a physician in the room, when you have a limited amount of time with a patient, and that's become a huge issue in the United States, we have less time with every passing year, I feel like, with our patients. And so as a physician, we focus on the prevention of organ damage, as Ricard said, because that's clearly absolutely critical so we can maintain longevity of our patients and function of our patients. But that being said, they're living their lives on a daily basis and experiencing a myriad of symptoms such as severe fatigue, right? 90% of our patients have fatigue, pain, as Jeanette said, depression, anxiety, stress, social isolation, body image, especially in our younger, women. These are all incredibly valid issues. And the challenge that I struggle with and my colleagues struggle with is how do we adequately address all of these in a short period of time? And my personal feeling is we need a multidisciplinary care model where we can rely on colleagues, for instance, our people that are specialized in nutrition, physical therapists who can help with physical functioning, mental health specialists, social workers. And the struggle in the United States is our healthcare system is not set up to do that. And so what we end up doing is in each individual center, we try to put something together that will benefit our patients and find those other colleagues who can work with us. And so maybe I only have 20 minutes with my patient and I have to focus on their lupus nephritis because that is a major issue that is going on right now. But that I can then talk to my patient, at least elicit the fact that they're concerned at that moment in time with their fatigue, depression, social isolation, but have that colleague that I can refer my patient to make sure there's a plan in place to address the other aspects that are going on in their lives. And this is, I think, the ultimate struggle. As Jeanette pointed out, one of the unique aspects of being a rheumatologist, especially who takes care of lupus patients, a lupologist, is that lupus affects every organ system in the body. And so we have to be very good internists, and we have to ask questions to make sure we understand about all the various symptoms and signs that our patients are experiencing. And we have to figure out a way to do this. And I think, I think we're going to get to this a little bit later, but I think we're finding that one of the ways that we can do this is to have, as we call them, patient-reported outcome instruments. So perhaps a patient can complete this while they're in the waiting room, right? So even if I only have 15 minutes or 20 minutes with a patient, that can be completed in the waiting room. That then gets transmitted to me. I can make sure that I can review that so nothing is missed. And maybe I can't address the severe fatigue right at this visit, but I know to then schedule my follow-up visit with that patient to address that. Because often I think the problem is we don't even ask as physicians, right? We don't ask. We focus so much on more of the classical lupus manifestations, arthritis, rash, nephritis, the things that we measure on physician disease activity indices, right? The classical things that we measure in clinical trials, but we're now learning that there's so much more that we need to be measuring and asking about. And how do we do that in day-to-day practice and make sure those issues get addressed? I think podcasts like this, where we're talking about these issues and raising awareness, will force us to really figure this out together as a community so we can better take care of our patients.
Thank you, Maria. And we're not addressing it later, we're addressing it now, patients-reported outcomes. Yeah. So beginning with you, that you raised the question, of course, that scales and scores takes time to fulfill. So the patient is not waiting 2 hours or 3 so they can fulfill all the patient's outcomes that we want. So if you had to choose 2, probably 3 scales for the patient's reported outcomes, what would be the ones that you would choose to apply to your patients in every visit?
It's such a great question, Raquel. We're trying to figure this out. So one of the instruments that my center is studying, we have a large longitudinal cohort of lupus patients, as does Ricard, that we're following, that's funded by the Centers for Disease Control in the United States. And so one of the measures that we are assessing and learning about in our cohort are the NIH PROMIS measures, which cover a variety of domains that are very important to people living with lupus. And we've gotten feedback from our patients on these domains, things like pain, fatigue, physical function, emotional distress, ability to participate in societies, body image, things like that. What's nice about this particular scale is that it is available in multiple languages, which is one issue that we face where I am. We want to make sure this is applicable to everybody. And these measures are generic in that they can be applied to different rheumatic diseases. So we can compare our experience with lupus to our experience with rheumatoid arthritis, to our experience with scleroderma. And that makes, I think, this very nice. So we're studying this right now in our cohort to see if this makes sense and if this can be useful. I think there are, and so as I said, that is not, the PROMIS measures are not specific for lupus.
Yes.
But they include domains that are very important to people living with lupus. And I think in terms of lupus-specific ones, the one that many of us use is the lupus qual. Now, we've used that in research. I'm not using that in routine clinical practice. And then there are measures of fatigue, so the FACIT score. We're in my longitudinal cohort, we're looking at measures of trauma, of stress. The perceived stress scale is one of the ones. We're also looking at frailty. But I think the caveat, one thing I should say, is that all these different measures that we're trying to understand, and we're trying to understand which ones are most applicable, which ones do patients find to be the most valuable. We are doing this in the context of our research studies because we have more time with our patients, right? So the struggle is, I think when we figure this out in the research setting, we can hone things down to what are those, as you said, Raquel, maybe those 2 or 3 measures that we can use in the clinic that will be most valuable to our patients with lupus, that will convey the information of their experience to their physicians. We're not quite there yet to know which ones to put into the clinic, but we're studying them.
Ricard, do you use patient-reported outcome on your clinical practice? What are the scales that you are using to your patients in your clinic?
Well, similarly to what Maria stressed, when we are doing research, nowadays it is essential to have patient-reported outcomes for most of the clinical trials and many other research projects. So we do, because we do this kind of research. But in a busy clinic, in a daily busy clinic, I really understand that probably this is very difficult to perform, even to perform before entering into the physician's room. This take times, and then obviously you have to analyze this. So what I always recommend is at least to listen to the patient, to these general quality of life symptoms that always patients want to stress. Listen to the fatigue, to the pain, to the pressure, to the brain fog, to these things, just to listen and to record these things. So probably this will not take a lot of time. It's not necessary to fill a list of items, but listen to this, not just stress if the patient has arthritis or a rash, or how is the proteinuria level, or what is the anti-DNA levels. So just stress and talk with the patient for a few minutes on these important aspects, and try probably to convince them on the importance of probably some daily life activities that can improve these problems, irrespective of the drugs, of the steroids, hydroxychloroquine or belimumab, or the other drugs that we can perform. So there are many daily life activities that the patients can do and will improve this quality of life symptoms. So just the idea, take a few minutes to talk on these things, irrespective if you fill a long list of items from a score that usually this is mainly for research activities.
Thank you, Ricard. Jeanette, now what's your view on what are the most important patient-reported outcomes on a clinical practice? And what are the tools that we can have currently, both technology, apps on your iPhone or iPad that you can use? And for you as a patient advocate, and as a patient, what are the main things that you want your doctor to know? Both Maria and Ricard didn't talk about a specific patient-reported outcome, that is the patient's notion of the lupus activity, which is quite different from the doctors. So what do you think are the main PROs that can be used in the clinic as we know it right now?
Yeah, well, there are many different ways to do it. And today we see it being done in different ways. There's definitely something to be said about having those few minutes, even if we know that sometimes you only have 15 minutes to see your patient. And during that time, you need to go through all the clinical results. You need to go to a medication list and so on and so on. But just having 1 minute to sort of look your patient in the eye, ask them how they're doing and what's going on in their life. If they have anything in particular they want to ask, that's a very big plus. Alone being asked, we know already it makes a lot of difference to the individual patient. Already that can make them feel better, that somebody is interested in how I'm feeling. Then we have different models from different countries that are being used now. We have, for instance, in Denmark, where I live, we have actually a questionnaire that you can fill out at home on your phone or on your computer before you go to the clinic. So when you get your call that you're going to have to go to the clinic this time, you get a reminder. With the reminder, you also get a link. That link goes to the Danish biobank. And in that biobank, they know that, I have lupus, so I get a lupus questionnaire. The questionnaire consists of a version of EQ5D with some FACIT elements and some SLE elements as well. So they try to sort of combine several things. Takes from 20 to 30 minutes to complete. You can also do it in the waiting room before your appointment. So what happens is when you fill all those things out, if there's a red flag, if something has changed a lot to the worse from your last appointment, your physician gets a notification on the red flags. So he knows when you get in, oh, maybe there's something we need to address today. I can see you have more fatigue than you usually do. Is something particular going on? Is there something you want to tell about? Or is it because you couldn't take your medication, or sort of getting the conversation going? And maybe it might be nothing. Maybe they just had a bad day when they filled out the questionnaire. You never know. But at least you have asked, and you have a peace of mind, and the patient as well. Something similar is being done in Portugal and other places. Then there are those apps that you also talked about. So today we have a lot of great apps and a lot of not so great apps. Some of them are for monitoring, and I know a lot of patients like to monitor the disease. They like to sort of be able to put in, especially when they're doing really bad. They want to be able to put into something, tell a machine that they're doing bad, and that might also help a bit. They're often not connected to the physician at all. But some of them have the opportunity, you can print out your details so you can see the development in the last 3 months, because we all know how difficult it is to remember what happened 3 months ago or 6 months ago. Sometimes it's even difficult to remember what happened 2 weeks ago. So reminding yourself about what happened is often good. My experience is that patients often get tired of those apps, and at some time they will stop using them. So I think something official from the hospital actually works a bit better. There's also other apps you can use, so sort of prescription apps. Most of them are wonderful because they mean that you don't have to call the clinic every time you need a new prescription. You can renew it on your app. You can see how many prescriptions you have left and when you got it filled out last. So it's easier for you and for the department, and you can save time that way. It's also good for a patient point of view, that you can prepare for your appointment, that you go into the appointment with a list of things you need to address. So, and you put the list on the table in front of you, between you and the physician, and say, these are the things I need to address before I walk out that door. So both you and the physician know, because you can have them in your mind going in, but by the time you've gone through all the different results and all the different messages, you'll forget. So to have that list is a help both to you and to the physician, knowing that these are the things we need to address. And also to make sure that you have an alignment of expectations. We know that lupus patients, we need to be the experts on our own disease. We need to know what to keep an eye out for. So I have skin lupus, I need to keep an eye out for these small marks on my skin. If they appear, I need to call my clinic. I have chest pain, and I usually have pericarditis or pleurisy, so I need to call my department and ask them, and maybe go in to have an appointment. Things like that are really important. So you can sort of, the physicians can rely on the patients to let them know when they feel it's time to be seen, and to maybe catch a flare before it actually becomes a real flare. And that self-monitoring is really important when you're dealing with a complicated disease like lupus. And there was so many great examples. I can't think of them all.
And this kind of education, it's time-consuming. So, what do you think is the right place for this kind of education, for the patients to know in their lupus, or the usual symptoms that their specific lupus have, what are the red flags for to call the physician? What are the main things that should be monitored? Do you think it's a physician education space? Do you think that the patients' associations have a role in this? Where do you think a lupus patient should have? What's the right place for this education?
Well, yes to all of the above. So I think, yes, the physician needs to know, of course, and they need to know how to relay the information to the patient. And if they don't have time during the consultation, they need to have other ways of doing it. For instance, through those collaborations in the clinic, where you have, for instance, a rheumatology nurse, or if you're very lucky, a lupus nurse who can bring that information on, psychologist, whatever specialty you're working with, that might have more time, but it's definitely also a role for the patient organization. I can give an example. In Denmark, I run a lupus course for newly diagnosed lupus patients, where we invite physicians, we invite lupus nurses, we invite psychologists, and so on, to go through all the different phases of a lupus person's life and telling them about, so what's important for you, what should you be aware of. They can have that one-to-one conversation that they can't have in the clinic when there's a limited amount of time. And maybe also get a connection to someone else. At the same time, they're learning about the patient organization, so they know where to go if they have any questions. So that's a win-win for everyone, I think. And I know that the physicians who have been taking part in those courses, they learn a lot too, because they learn a lot about which questions patients have, what they might be able to address in the next consultation they have, and so on. So I think we need to learn on both sides of the desk.
So you are telling us a tale of almost perfect management of lupus in Denmark. And that's a huge work we have to do to take this kind of model to all the rest of the Europe and North America, and eventually one day to the rest of the world. And as you said on the beginning, you are a highly educated patient representative. So, and I think you actually use the words that saying that we speak on the same language. So we can speak on a medical language. So you as a patient, as a highly educated patient, move to speak our language. So, and we also have to do the effort to speak a lay version of our language and to speak to the patients. But even with this, not every patient he's highly educated, and not every doctor has the capability to do a lay version of language. So patients are highly heterogeneous, and doctors also in their personality characteristics. So different native language, even in several countries, different dialects of the same language, and cultural interpretations of different kinds of tones and ways of speaking. So as if lupus was not difficult enough, the patient-doctor communication also have a language pitfall to deal with. So in your personal, but even more in your professional experience as the chair of Lupus Europe, what do you think it's the importance of language and understanding these differences, and what can we do to overcome this difficulty?
Yeah, it's a very difficult question, because it's not only in disease management, right? It's all throughout society. We have those cultural differences, the language differences, and just understanding your neighbor can sometimes be hard because you don't know the same things, you don't have the same frame of life. But I think one of the things I've noticed is we have some cultural differences that we might be able to also change a bit by learning from each other. I can give an example. So I was speaking with a German lupus professor. He's very strict and he's really talented. But we were talking with him about those PROs and that conversation between patients and doctors. And I said, one of the things that doctors don't take up much, especially male doctors, is sexuality. Something happens with a patient's sexuality when they get lupus, especially if they also have Sjogren's and so on, right? Not only about pregnancy, but around everything. And it was like, you could see in his face, I cannot talk with my patient about sexuality. It was completely outside the realms, but outside what he was able to cope with.
Yes.
So it's that thing where you sort of, what can you talk about? what are the limits and what is needed to talk about. That's where you, as a physician, sometimes need to go outside your own comfort zone. And you are a person like we are. So you might have difficulties doing that simply because of the person you are. And having a sort of a checklist can sometimes help. So if you have a piece of paper, so it's not me deciding and we need to talk about this, but it's on my paper, so we need to talk about this. That sometimes helps. And if the patient says, oh, I don't have any issues, it's even better because dodge that bullet. And then having some answers prepared if there actually isn't an issue. So you have some prepared answers you can give, even if you get flabbergasted yourself and you don't know what to say. And that's a help sometimes, having a list. Can also help with the difficult language. So if you have some medical terms you need to explain to your patient, look them up beforehand and see. So how is a good way to explain this? Ask the patient organization. Sometimes they have flyers about different areas of disease where you can actually get help. You can get a lot of good information from patient groups. They do all the research. You don't have to. So you can go directly to them. They often have websites where it's explained item by item. You can print them out. You can hand them out as leaflets. We have something like the Lupus 100, where Lupus Europe have created a website where you can go and look up what's the 100 most asked questions from patients and get the answers. And you can get them in your native language and in a language that patient understands. So you have so many tools to use, and that's where you can make good use of the patient organizations.
Thank you, Jeanette. Maria, do you have any story that you'd like to share with us about miscommunication due to language or tone between you and a patient? What's your experience as a physician on this miscommunication due to language and cultural issue and tones?
Yes, I think this is such an important question, an important point to discuss. And I think that we face this almost every single day. Where I am, it's and I think for many of us, it's a very multicultural environment with many languages and dialects. And we're often, we're better now at having interpreters who can be with us in the room, either via video, that has really been able to expand our access to all sorts of interpreters, or in person. But it's still not the same speaking through an interpreter. And it's a challenge that we face. And we're trying to get better about how do we connect with the patient in front of us to the best of our ability, knowing that we don't have the same primary language that we're speaking through this other person. It can be very challenging. And then another challenging situation that we face is sometimes a patient will bring, for instance, a child, a young adult child who speaks, in my situation, English, let's say the parent speaks only Cantonese, but the child can speak English. But then I always have felt that that's not always appropriate, right? Because there are certain things that you might not want to speak about in front of the adult child. And so we always insist on making sure we have an external interpreter that comes in. So that's one thing that we always do, and not just to rely upon a family member who might be having their own context and their own interpretation of what is being said, and we don't know if they're actually relaying the appropriate information to our patient. But this is a challenge, and it's very critical especially in a disease like lupus. And Jeanette, you hit upon this, that educating our patients as to what to expect and what are some early signs of flare, the importance of going to the laboratory to have the routine laboratory sent so we can pick up things like lupus nephritis early. That education is absolutely critical. And then we add the complexity of trying to educate in a different language. How do we do that? But these are issues that are I think, universal for many of us and very important to try to figure out.
Ricard, do you have any episode that changed the way you see this mismatch and miscommunication with patients?
Well, probably what I can just stress is the importance of this multidisciplinary team to deal with lupus. And in addition to nurses, in addition to physiotherapists, in addition to psychologists, we probably need also a specialist in communication, probably these translators or these just experts on the way that we translate the communication. And we probably write this in websites, or we made the podcast, or we made the video recordings for the patients and so on. So I think that the way that we communicate is very important. So let's put this expert on communication also in this multidisciplinary team.
I was trying to figure out what would be the summary of this podcast, just to close it. And I was thinking, all the podcast is the summary of this issue. It's so important, everything. Ricard stressed on the beginning that the patients' representatives and the advocates and the associations are really important for showing what we need to do to the administrations, to the politicians, so we can do better. And if not for every other thing, we doctors are lupologists because we want to treat better lupus patients. So the patient is the center, but it looks like that for several decades it was forgotten, and now it is coming again, and we need to relearn that, and we need to talk with the patients, and the patients also need to know that they are really, really important on the way we treat the patients. So please, if you didn't understand anything while you were listening, just come to the start and listen again, because there's no possible way of summarizing these so important issues. So Jeanette, thank you so much for being with us today. Maria, thank you. Ricard, thank you so much for this conversation that I really enjoyed. I hope you also enjoyed. To our listeners, we hope these discussions have helped you gain more of an understanding of lupus and the importance of the patient perspective when we are treating lupus. Do send us feedback on cases you would like us to discuss in the future. Thank you so much for listening. We hope you enjoyed this podcast. Please leave us a review, which will really help us in reaching as many of your colleagues as possible around the world. Join us again next time.